Assalamu alaikum students. Last week we have started the gross anatomy of eye, and so far we have done the structure of eyeball and extraocular muscles. Today we will study the nerves of the orbit. Nerves of the orbit include some of those nerves which only pass through the orbital cavity to supply the area of face and scalp. These include branches from ophthalmic and maxillary division of trigeminal nerve, while some are cranial nerves. Cranial nerves include optic nerve, which emerge through the eyeball, and third, fourth and sixth cranial nerves which supply the extraocular muscles in the bony orbit. The orbital cavity also contains ciliary ganglion, which is parasympathetic ganglion. Now this diagram is showing the various nerves in the orbit. Most of the nerves enter through superior orbital fissure and some from inferior orbital fissure. They supply either within orbit or they supply the areas of face and scalp. Just an overview of the nerves branches from the ophthalmic division of trigeminal nerve, which we have already done. This one is a frontal nerve which divide into supratrochlear and supraorbital nerves. This one is a lacrimal nerve, and in this diagram we can see the nasociliary nerve. Nasociliary nerve enters the bony orbit through superior orbital fissure. Then it crosses the optic nerve from lateral to medial side and runs along medial wall of the bony orbit. During its course, it gives communicating branch to this ciliary ganglion. Then 2 or 3 long ciliary nerves which pierce the sclera. Posterior and anterior ethmoidal nerves which pass through posterior and anterior ethmoidal foramina and canals to reach the anterior cranial fossa, and this terminal branch, that is infratrochlear nerve. The cranial nerve include number 1, optic nerve. Optic nerve is the second cranial nerve, and it is purely sensory nerve for the special sense of vision. The fibers of the optic nerve are axons of the cell in the ganglion cell layer of the retina. They converge on the optic disc and exit from the eye about 3 to 4 millimeter medial to posterior pole of eyeball and pierce the sclera, and that part of sclera is called lamina cribrosa. Optic nerves are surrounded by all the 3 meninges with subarachnoid space, and this subarachnoid space is filled with cerebrospinal fluid. The meninges extend all the way to eyeball. The optic nerve passes posteromedially in the orbit and exits through optic canal and reaches the middle cranial fossa, where it forms the optic chiasma. Its course in the orbit is somewhat tortuous to allow the free movements of the eyeball. Some relations of the optic nerve are important in the bony orbit. First of all, near the apex, it lies supromedial to ophthalmic artery. You can see in this diagram just near the apex where tendinous ring of Zinn is attached, and optic nerve is present within optic canal, and this one is ophthalmic artery which is present infralateral to it. It is optic nerve, then after emerging through optic canal is surrounded by cone of all the 4 recti muscles, and it is separated from the lateral rectus muscle by the 3rd and 6th cranial nerves with nasociliary nerve. It is closely related to origin of 4 recti, whereas more interiorly where the muscles diverge, then it is separated from the muscles by the orbital fat. Just beyond the optic canal, the ophthalmic vessels and nasociliary nerve, which are present initially on the lateral side of the nerve, they cross the nerve from lateral to medial side. This is nasociliary nerve, and this is ophthalmic artery which crosses from lateral to medial side. The central artery of the retina enters the substance of the optic nerve about halfway along its length and enter the eyeball with it. While near the back of the eyeball, the optic nerve becomes surrounded by the long and short ciliary nerves and vessels. After the optic nerve emerge through optic canal and reach the middle cranial fossa, it unites with optic nerve of the opposite side and it forms optic chiasma. Here its anterolateral angles are continuous with the optic nerves and the posterolateral angles are continuous with the optic tract. Now in this diagram we can see the fibers from the nasal half of the retina from each side cross or decussate at the level of optic chiasma, while the fibers from the temporal half of each retina will continue on the ipsilateral side as optic tracts. Now optic tract consists of nasal fibers from the opposite hemiretina and temporal fibers from the ipsilateral hemiretina. These optic tracts continue posterolaterally on each side of the midbrain and reach the lateral geniculate body. Now lateral geniculate body is actually nucleus of the thalamus and consists of nerve cell bodies. Most of the fibers synapse here, while few fibers reach the midbrain and terminate in the nucleus of superior colliculus and pretectal nucleus. These are nuclei in the midbrain which are concerned with visual reflexes, and we will study in neuroanatomy inshallah. Then axons of the nerve cells within lateral geniculate body leave it to form optic radiation. The optic radiation passes posteriorly and terminates in the visual cortex, which is present in the occipital lobe of the brain. अब विजुअल पाथवे में हमने सबसे पहले अंडरस्टैंड करना है कि व्हाट इज़ फील्ड ऑफ विजन. Field of vision is a total area in which the objects can be seen when one focus on a central point. That is called field of vision. So field of vision को हम दो parts में divide कर सकते हैं, एक temporal field of vision और दूसरा nasal field of vision. जो temporal field of vision है, it is seen by the nasal half of the retina. It forms the image on this nasal half of the retina, while the nasal field of vision is seen by this temporal half of a retina. When the fibers axons pass in the optic nerve, then the fibers from the nasal half they cross, they decussate and enter the optic tract of other side like this. Now the optic tract consists of nasal fibers from the opposite side and temporal fibers from the ipsilateral retina. Then they will continue as optic tract and reach the lateral geniculate body. From there optic radiation arise and they will terminate in the visual cortex. हम ये details दोबारा पढ़ेंगे जब हम न्यूरोएनाटमी पढ़ेंगे. अब ऑप्टिक नर्व से रिलेटेड कई रिफ्लेक्सेस हैं जो आपने फिजियोलॉजी में पढ़ लिए होंगे. एनाटमी से रिलेटेड कुछ रिफ्लेक्सेस हम न्यूरो एनाटमी में पढ़ेंगे. यहाँ हम डिस्कस कर रहे हैं कुछ सिंपल रिफ्लेक्सेस लाइक प्यूपिलरी लाइट रिफ्लेक्स. ये क्या है? रैपिड कॉन्स्ट्रिक्शन ऑफ द प्यूपिल इन रिस्पॉन्स टू लाइट. दिस इज कॉल्ड प्यूपिलरी लाइट रिफ्लेक्स. द एफरेंट लिम्ब फॉर दिस रिफ्लेक्स इज थ्रू ऑप्टिक नर्व, while the efferent limb is through third cranial nerve, that is oculomotor nerve. Oculomotor nerve contain parasympathetic fibers through Edinger-Westphal nucleus, which supply the sphincter pupillae muscle in the eyeball, and this sphincter pupillae muscle cause constriction of the pupil in response to light. Interruption of these fibers causes dilatation of the pupil because of unopposed action of dilator pupillae muscle, which is supplied by sympathetic fibers. The next is accommodation reflex. When the eyes are directed from a distant to a near object, contraction of the medial recti bring about convergence of the ocular axis and lens thickens to increase its refractive power by the contraction of ciliary muscle. Pupils constrict to restrict the light waves to thickest central part of the lens. The efferent impulses again travel through optic nerve while oculomotor nerve carries efferent impulses. This diagram is showing the pathways of both the reflexes, light reflex, pupillary light reflex and accommodation reflex. Now nerve supply of the extraocular muscles, इसके लिए ये फॉर्मूला याद रखें, LR6 SO4 R3 chemical सा फॉर्मूला, LR6 for lateral rectus and 6 is for abducent nerve, SO for the superior oblique and 4 is trochlear nerve. R is for the rest, means rest of the muscles are supplied by third cranial nerve. So LR6 SO4 R3. I have already discussed the third, fourth and sixth cranial nerves in my video lecture, and you can see the nerves in the diagrams. This one is oculomotor nerve emerging through medial aspect of crus cerebri. This one is trochlear nerve, the only nerve which emerges through posterior aspect of the brain stem, and this is the sixth abducent nerve which emerges through pons medulla junction. In this diagram we can see the nerve supply of extraocular muscle. This one is oculomotor nerve, its upper and lower divisions. Upper division supplying the two muscles while its lower division supply the three muscles. This one is a nasociliary ganglion. This is lateral rectus muscle and which is supplied by the abducent nerve. And this one in purple color, this is trochlear nerve which supply only one muscle, that is superior oblique muscle. The next is ciliary ganglion. I have discussed the ciliary ganglion in detail in my video lecture. Ciliary ganglion is a parasympathetic ganglion which is for innervation of certain intraocular muscles. It is a small, flat, reddish grey swelling which is connected to nasociliary nerve, but functionally it is related to oculomotor nerve. It is located near the apex of the orbit in loose fat, where it lies between the optic nerve and lateral rectus muscle. This is an important relation of the ciliary ganglion. As in all peripheral parasympathetic ganglia, it also contains three roots or connections: parasympathetic, sensory and sympathetic. These three roots enter the ganglion through its posterior aspect. The parasympathetic root, as I have discussed in video lecture, contain preganglionic parasympathetic fibers from the Edinger-Westphal nucleus, which is parasympathetic nucleus in the midbrain. They join the oculomotor nerve, then its inferior division, and then branch to inferior oblique and leave the nerve to reach the ganglion. Only parasympathetic fibers synapse in the ganglion. This is the diagram which showing the location of ciliary ganglion. This one is ciliary ganglion between the lateral rectus muscle and optic nerve. Optic nerve is not present in this diagram. And this one is the schematic diagram which showing the three roots of the ciliary ganglion. We have already discussed in detail. Sympathetic root consists of postganglionic fibers which are derived from superior cervical ganglion form the plexus around internal carotid artery within cavernous sinus. These fibers join the nasociliary nerve and travel to the ganglion in its sensory route, and they traverse the ganglion without synapsing. Sensory route passes through ciliary ganglion are derived from the nasociliary nerve. So these three connections reach the ganglion, but only parasympathetic route synapse here. Then 8 to 10 short ciliary nerves emerge from the interior aspect of the ganglion. These are called short ciliary nerves, and each of the nerve contain all three type of fibers: sympathetic, parasympathetic and sensory fibers. Now postganglionic parasympathetic fibers which travel in the short ciliary nerves, they supply two intraocular muscles. One is sphincter pupillae and other is ciliary muscle. And sympathetic fibers supply the blood vessels of the eyeball, but remember, as you know, dilator pupillae muscle in the iris have sympathetic supply, but this sympathetic supply is not through these short ciliary nerves, but actually these sympathetic fibers travel through ophthalmic division of trigeminal nerve, then join its nasociliary branch and then along long ciliary nerve and supply the dilator pupillae. So the sympathetic fibers for dilator pupillae travel along long ciliary nerves to reach the muscle. The sensory fibers carry sensations from the cornea, ciliary body and iris. Again, the diagram showing the location of ciliary ganglion, and it is suspended with nasociliary nerve. These are the short ciliary nerves which pierce the sclera to enter the eyeball. They run in the perichoroidal space, and this simple diagram showing how the three roots reach the ganglion and then the fibers travel in the perichoroidal space and supply the structures. Now we will discuss few important clinical points related to extraocular muscles and their nerve supply. Number one is strabismus, which is also called squint. This is due to weakness or paralysis of muscle, and in this condition, when one looking at an object, the two eyes do not properly align with each other. It can be paralytic or concomitant squint, which is an acquired type of defect, and it is due to diseases of third, fourth or sixth cranial nerves which supply the extraocular muscle. The squint is maximum when the patient looks in the direction of action of weak muscle, and in this type of squint, movements are limited and there is diplopia, that is double vision. While concomitant type of squint, it is congenital and there is no limitation of movement and there is no diplopia in this type of strabismus. Paralysis of extraocular muscles due to injuries of cranial nerves. Oculomotor nerve palsy. Oculomotor nerve or third cranial nerve supply all the extraocular muscles except lateral rectus and superior oblique. It also supply two intraocular muscles जो कि हैं sphincter pupillae and ciliary muscle, because the parasympathetic fibers through oculomotor nerve which reach the ciliary ganglion and then supply through short ciliary nerves two muscles, sphincter pupillae and ciliary muscle. So in this condition, when the superior rectus, medial rectus, inferior rectus and inferior oblique, they all are paralyzed, the eye can't move upwards, downwards and inwards. Now oculomotor nerve also supply levator palpebrae superioris, so it will result in drooping of superior eyelid. The condition is called ptosis. Then pupil is fully abducted and depressed. Now why abducted? due to unopposed action of lateral rectus, and Y depressed due to unopposed action of superior oblique muscle. So pupil is abducted and depressed. It is called down and out. आपने कैसे याद रखना है इसको? Down and out means third nerve palsy. It is called lateral squint क्योंकि eye pupil deviate हो गई है, abducted हो गई है laterally, and it is called lateral squint or external strabismus. Next is the pupil is fully dilated. Now why it is fully dilated? Because the sphincter pupillae muscle is paralyzed, which is supplied by the parasympathetic fibers through oculomotor nerve. That's why there is unopposed action of dilator pupillae, which is supplied by sympathetic fibers, right? Loss of accommodation, we have just discussed the accommodation reflex. The efferent limb is by oculomotor nerve, so it is also due to paralysis of ciliary muscle. And due to squint there is diplopia or double vision. अच्छा जी, अब जैसे कि हमने पढ़ा कि इन द oculomotor nerve parasympathetic fibers lie superficial to motor fibers. So in case when there is an incomplete lesion of the oculomotor nerve, or there are conditions with raised intracranial pressure which cause compression of the nerve, in this case they may spare the extraocular muscles or the intraocular muscles. The condition in which innervation of extraocular muscle is spared but there is a selective loss of parasympathetic supply which supply the sphincter pupillae and ciliary muscle, this type of injury is called internal ophthalmoplegia, means weakness of internal muscles. As sphincter pupillae muscle cause constriction of the pupil, so in compression injuries the initial sign may be only dilatation of pupil. And the condition in which sphincter pupillae and the ciliary muscle are spared means intraocular muscles are spared, but there is paralysis of extraocular muscle. This type of injury is called external ophthalmoplegia. In this diagram you can see the oculomotor nerve palsy on left side. This is normal eye with normally positioned pupil, and in this you can see ptosis, drooping of the upper eyelid, and in and out position of the pupil, and the pupil is dilated. This is oculomotor nerve palsy. The next is trochlear nerve palsy. Trochlear nerve supplies only one muscle in the orbit, that is superior oblique muscle. For understanding the effects of injury, you must know the normal actions of the muscle. Superior oblique muscle rotate the eyeball downward. It also causes abduction and intorsion of the eyeball. Fourth cranial nerve or trochlear nerve rarely paralyzed alone, but if it is paralyzed, it will result in defective depression, especially in the adducted position of the eye, because superior oblique muscle cause depression in adducted position, and this is the only muscle which cause depression in adducted eye. The characteristic sign of trochlear nerve injury is diplopia, double vision, when the patient looks down, and the person can compensate for the diplopia by inclining the head laterally towards the side of normal eye. The next is abducent nerve palsy. Abducent nerve, like trochlear nerve, also supplies only one muscle, that is lateral rectus muscle. What is the normal action of lateral rectus muscle? It causes lateral rotation of the eyeball. So in a lesion of the abducent nerve, the patient cannot turn the eye laterally. In this diagram we can see this is normal eye, and this is with lateral rectus muscle paralysis, and the eyeball is present in adducted position. When the patient is looking straight ahead, the lateral rectus is paralyzed and the unopposed medial rectus pull the eyeball medially. This condition is called internal strabismus or medial squint. It also causes diplopia or double vision. And in the last, Horner's syndrome. Horner's syndrome results from interruption of sympathetic supply from a cervical part of sympathetic chain, especially superior cervical ganglion. It will result in constriction of the pupil, that is called miosis, drooping of the superior eyelid, the called ptosis, redness and increased temperature of the skin due to vasodilatation, and absence of sweating, that is called anhidrosis. Now, constriction of the pupil occurs because the dilator pupillae muscle is supplied by sympathetic fibers and that is paralyzed, and there is unopposed action of sphincter pupillae that is supplied by parasympathetic nerves. Similarly, ptosis is due to paralysis of smooth muscle part of the levator palpebrae superioris, and that will result in partial ptosis. So this was all about the nerves which are present in the orbit and the various important clinical correlates. Thank you so much.